Good evening. I'm Dr. Joel Silverfield, who's president of the Hillsborough County Medical Association. Welcome to our 7th seminar on COVID. We've got a wonderful panel of folks. Before we start, though, I'd like to say that as hard as we have it here with all we're dealing with our COVID situation, our hearts and souls go out to those in Louisiana who are not only dealing with what we're dealing with, but also dealing with the massive hurricane, lack of energy and all those things. So our hearts go out to them. There's also a reminder on September the 14th, we are very fortunate to have Dr. Robert Califf joining us. Dr. Califf is a former FDA commissioner under Barack Obama. He started the Duke Clinical Research Institute, which is the largest of its kind in the world. He's in the top 10 most cited medical authors. And he currently is head of Google strategy, healthcare strategy. So I tease him and say that he's actually Dr. Google when my patients come up with that. So he'll be with us September the 14th. Unfortunately, because of COVID, he will also be doing it remotely. When I think about how this is changing from our last time, it was a more optimistic time a few months ago. It reminds me when Justice Oliver Wendell Holmes was being accosted by a reporter saying, well, Justice Holmes, your opinion has changed from last year. And he said, well, when the facts change, so does my opinion, and you, sir. So our opinions may be changing from the last time you listened in. It reminds me of about last February or March of 20, I was at a gathering at the Oxford Exchange, a restaurant in South Tampa, and the owner, who's a friend of mine, came up to me. He says, Doc, I've been hearing something about a virus in China. What do you think about that? And I said, well, I've read some things about it, and the Chinese say it's not transmitted from person to person very easily, and that they've got it well contained. So that's why I'm not one of the panelists tonight. But we do have some wonderful panelists tonight, starting with Dr. Margarita Cancio. She is the medical director of Infectious Disease Associates of Tampa Bay. She is an affiliate professor at USF College of Medicine. We have Dr. Douglas Holt. Dr. Holt is health officer of the Florida Department of Health in charge of Hillsborough County. He is a professor of medicine at the University of South Florida and the Division of Infectious Disease and Internal Medicine. We have Dr. Charlie Lockwood with us. He is the Dean of the Medical School. For some reason, that seems to me to be more important than being USF Vice President for Health, but it probably pays more to be the Vice President. But he's the Dean of our medical school here, and they've done a wonderful job there. And then we have Dr. John Sennett, who is a scientist. He puts that first, which I love, and the Chairman of Internal Medicine at USF, Director of the Florida Infectious Disease Institute, and former Associate Dean of the USF College of Medicine. So we've got a lot of things going down, a lot of questions. I'm going to start with a few for Dr. Cancio. So this is going to be a pretty fast hour that we go through. So Dr. Cancio, as far as, I'm going to give you a couple of clinical situations, if you would let us know. Someone who is vaccinated, they're exposed to someone who is COVID positive, who just got COVID. So my question would be, how long do they quarantine? And does the Delta variant mean that they quarantine any longer? So you've got someone who is vaccinated, who is exposed, but has no symptoms. What should that person do?
Well, that person depends on whether that person is immunocompetent or immunocompromised. So it's the same rules they need to watch out for their symptoms, and they should consider testing themselves at 3 to 5 days, usually 5 days, and they need to so that they can know whether they're positive or not, which at 5 days will be an important time to test themselves. And but they would be they should isolate themselves for between 7 to 10 days. But if at 5 days they're negative, that's a very good thing in terms of exposures. If the person is positive, then they need to isolate themselves for 10 days if immunocompetent, and 20 if immunocompromised. We should remember, though, that currently, as of the beginning of August, the monoclonal antibodies have been approved for not only therapy, but for prophylaxis. So if the particular person that has had an exposure is a person that is high risk for complications of COVID, even if they have been vaccinated, they will be eligible to receive monoclonal antibodies. That has to be done within 96 hours of exposure, and for those that have a high risk of developing complications. And that doesn't even need an IV infusion. They can be done subcutaneously. Actually, we're very grateful to that the University of South Florida Morsani College of Medicine has a very good program under the leadership of Dr. Guerra, we have been able to get patients treated, and that has to be in a different place than where you give them monoclonal antibodies for people that are already positive. So it's a little tricky in terms of how to go about it, but the point is that if you're exposed, you should be tested at 5 days. If you're positive, 10 days for immunocompetent, immunocompromised, positive individuals have to quarantine for 20. And if you are somebody that may at high risk of developing complication, monoclonal antibodies for prophylaxis within 96 hours of exposure are a really good idea.
So am I to understand then it really doesn't matter whether you're vaccinated or unvaccinated if you're exposed to a COVID positive person? Is that what you're saying?
Correct.
Okay, I think that's different from what the CDC was saying a while ago. So that's interesting. Okay.
Yeah, that's Delta is very contagious, and obviously all those that were vaccinated, especially very early in the pandemic, December, January, February, the antibodies are starting to drop, and that's why we're going to see recommendations of having that third dose coming sooner, booster, so to speak.
Right. We'll be talking.
Question will come later, but that's the point.
So we'll be talking about that in a minute then. Okay. Very good. So, there's been some controversy. Dr. Fauci is saying that the monoclonal antibodies are underutilized. And so you're making the point that they could be used as a preventative for someone who does not have COVID, but who is immunocompromised. And do you think they're being underutilized?
Well, in general, it seems that that there's a lack of information, and that a lot of physicians are not aware how important these monoclonal antibodies are. So they're probably underutilized, but they have had an indication for therapy early on. Is from the time you're positive within the first week before you actually develop your own IgG. That's when that early therapy, once you're positive, it can prevent the person from being hospitalized, from getting sicker. So, and there are many sites in the Tampa Bay area where those monoclonal antibodies can be prescribed, and the physicians should have access and should know where they have, and they go ahead and give it to anybody that is positive, especially those that if they get anybody that is not vaccinated within the first week, definitely should have it. Anybody that is vaccinated and would have complications, or that they should also consider it. Independently of that, I think it was like August 1st, the monoclonal antibodies emergency use authorization was extended to the prophylaxis indication. So now they can be used both for therapy early within the first week, for prophylaxis within 96 hours of exposure, for those that may have high risk of developing complications. And yes, we should probably could post in the website the sites in the area where physicians can send their patients to get this therapy.
Very good, thank you. Dr. Holt, the question is, who are we testing? Which test is a good test to use? Do the home tests work? And how is contact tracing doing for the county? So something about testing and then about contact tracing.
Yeah, there's again, there's been a plethora of tests that have been coming onto the market and available. One of the most important things you should know is that many of the home tests are not reported to the health department. So you may have a result, but it will not be acknowledged by the state. And therefore, by itself, will not act on any contact tracing or anything. We've seen a lot of this challenge in the schools where the parents are using these tests and come in. So it has created a lot of controversy or a lot of challenges to deal with that.
Are the home tests accurate?
Well, I think it's really kind of which test are we talking about, and that's part of your challenge. These home tests have yielded their best predictability when you are symptomatic or you have an exposure. But as far as working with asymptomatic screening, they have less reliability. I know, I think Dr. Lockwood used to have some very, very good calculations and numbers about just the challenges of this. And I think doctors, as always, we should be ordering tests that we know what we're going to use that result for.
Okay, how would you define exposure? What is considered a true exposure?
Well, it's a cumulative time around someone who's known to be infected of 15 minutes within 6 feet. They have, in some cases within the schools, they have reduced that to 3 feet when they're masking, and some others, but generally we're still at 6 feet distance. And that's cumulative. That's not 15 minutes in a continuous manner. You ask about contact tracing.
Yes.
With 1,600 cases a day, we are doing minimal effective contact tracing. It's very targeted. We're looking at our high-risk groups, congregate living, long-term care, and the schools are taking of course, lately an inordinate amount of time and resources because of the demands to determine is real time as fast as possible if a student needs to be excluded. And point of fact, I think if you see in our Pasco counties and others, it has gotten to the point where the fully acknowledged that the contact tracing is so delayed that by the time they're getting to the children who've been exposed, they're at the end, if not past their quarantine. So increasingly operationally, what you're seeing is parents being told, if they're sick, stay home, and if they're not, can come back. It's
very good.
We're not prepared for the onslaught that we have seen.
No, I heard when I was talking to someone the other day, and I said Delta was ready and we weren't. So let's see, Dr. Lockwood. So we deal a lot with vaccine hesitancy. And a lot of the patients are saying now, of course, that that the vaccine doesn't really protect you, that sort of thing. What are some things that you can think of that will help us convince our patients to get vaccinated? And how are things going nationally with lotteries and mandates and this sort of thing? I had an ex-buck in my office the other day, and he said he saw the NFL had vaccinated 96% of their players, and so he thought that was a good thing.
Yeah, I mean, obviously there are significant variations. For example, Massachusetts is about 80%, and most of New England is now 80%, at least one dose. And places like Alabama, John Senate's favorite state, Mississippi, unfortunately Louisiana, although Louisiana's actually a little bit better. The numbers are less than 40%. So There are obviously regional differences. I think Doug would confirm this, but there still is a significant lag in uptake for folks under 40. There's a significant lag in uptake among African Americans, Latinx patients, and particularly rural whites and working class whites. So it does fall along kind of interesting demographic and political lines, bipartisan in its appeal in that sense. Some of it is kind of the wacky left. And I don't mean to say Robert F. Kennedy Jr. is wacky, but I'll say that he's a major anti-vax person, and obviously on the right as well. So there's all kinds of mixed reasons. There's a lot of genuine fear and anxiety. I think that the message is really that the risk of significant side effects with the vaccine are 2 to 5 per million. And the risk of dying if you're 40 is 0.1%. If you're 60, it's about 1%. And if you're over 70, it's 11%. So, this is your brain and this is your brain on drugs. I think it's a pretty simple equation from a risk perspective. The risk of serious side effects is extraordinarily low. And the risk of significant morbidity, not to mention long-term sequelae, chronic depression, chronic lung disease, and so forth, is quite high, particularly as you get over 60. And so, I think proselytizing, going over the numbers over and over, reassuring, particularly, I mostly deal with young women, and there's a fear of infertility, there's a fear of pregnancy complications. The fact of the matter is, if you're pregnant, your risk of prematurity is increased dramatically, somewhere between 20 and 40%. Your risk of mortality is increased tenfold. Your risk of hospitalization greatly increased. It's just cosmically wrong not to get vaccinated if you're thinking about getting pregnant or you're pregnant. But the truth is, Hillsborough is challenged by all those demographics and the fact that we're a relatively young county. The percent of the population under 65 in Hillsborough is about over 65 rather, is about 14%. It's 21% in the state. So we are right in kind of the bullseye of anti-vax sentiment, fear, anxiety, all the reasons that all those 3 big demographic groups don't want to get vaccinated. We haven't done horribly despite that. We're not quite at the state levels, but we're pretty close. I think our job as physicians is just to preach to every patient we can get our hands on and try to convince them to do this. Someone texted me from Tampa General a couple of days ago and said that a patient had explained to them that they were making a political statement by not getting vaccinated. And I said, well, actually, I know of a 31-year-old male with 2 young kids who just made the ultimate political statement by dying at Tampa General. So, it's just astonishingly awful that we have this high rate of anti-vax feelings. On the other hand, the vaccine's not perfect. And obviously, it's about 65% effective against mild and moderate disease, but it is over 90% effective against death. So, the equation's pretty simple.
It's I've read a couple of analogies that I use with my patients from Dr. Nguyen, and she was saying that she says the vaccine is sort of like a seatbelt, doesn't necessarily keep you from having an accident, but if you have one, your chances of surviving are much higher. And then she also made it similar to a raincoat that would protect you from getting wet on a regular day, but if there's a storm of rain coming at you, it may not fully protect you. So has the FDA approval? I had a patient today that was saying he'd heard that the SEC had approved the vaccine. So I'm not sure what he was, Southeastern Conference or the Securities and Exchange Commission, but has the FDA approval, has that helped you at all?
There's been an uptick commensurate with it, but nationally and in the state, and Doug can tell us about the county, but I'm not sure whether that's really the reassurance of the approval or just terror of dying, given the ferocity with which the Delta variant is really wreaking havoc. Even in Massachusetts, where they had been very smug until just a few days ago, there is a huge uptick in cases. Now, I suspect the Northeast, given the seasonality of this thing, is going to start to see more and more cases just because people are going back indoors.
Well, back in the day, they used to be said in New York City, a liberal was someone who had not been mugged yet. So an anti-vaxxer may be someone who hasn't had the COVID, hasn't had a close friend or relative die from it. So one final question, is there anybody, because often I'll have patients say, well, I was told I shouldn't be vaccinated. Who can you think of who wouldn't be a vaccine candidate?
You know, the answer is, unless you had an anaphylactic reaction to the first dose, so that would be, you know, the 2 and 5 per million. There really is none. I mean, there's some potential if you have an allergy to polyglycine or polyethylene. Those are vanishingly rare allergies, but that's it.
Okay. All right. So basically that's a non-concern. Dr. Sennett, someone had asked a question, can you compare historically the COVID epidemic or pandemic we're dealing with to the one in 1918 that took so many people?
Yes. Both were global catastrophes. Interestingly enough, the one in 1918, the Great Influenza, originated in Kansas, in America, and was happy to spread along with World War I throughout the world. It got its name, the Spanish flu, because the Spanish during the First World War were neutral, and they made the observation that, you know, there's people dying all over the place and you guys are busy shooting each other in the trenches. Do you have any other ideas? Many people feel that the thought leaders at the time decided they were right. Back then, there's ample evidence that this disease was actually spread by birds as well. So that you might have an outbreak in Tulsa, Oklahoma one day, and 3 days later in Dallas, and no one could figure out how it got from one place to another. We were happy to export it to Europe on troop ships. And on the troop ships, the mortality was so high that they would anticipate that 1/3 of the troops would die of the great influenza on the Atlantic crossing. When it first started, they kept names, serial numbers, dates, and formal burials. By the end of the trip, they were just writing the name down and dumping the bodies overboard. It was a grievous epidemic. The reasons for it abating are unclear. No one really knows why this illness went away. They did, I think, in Philadelphia and San Francisco, deal very well with masking, and that the police were authorized to shoot you on sight if you did not have a mask on, which I thought was a very effective deterrent. I don't seem to be able to get that to fly in Florida, but I'll keep trying.
They're using it in China, I believe, yeah.
Today's pandemic originated in Wuhan, China, or thereabouts, probably within 50 miles, spread unnoticed across the world initially because so many patients that got it were asymptomatic or had mild disease. Since then, it seems to have mutated, but the mutations have occurred in the direction of becoming more virulent and more contagious. There is no selective advantage to this to attenuate. With the great influenza, you were sick. You were not contagious till you were sick, maybe 12 hours ahead of time. But with COVID, you're contagious 48 hours before you feel sick often. So this disease is readily spread. With the emergence of the Delta variant, I feel that we will surpass the great influenza. If you recall, the great influenza killed 675,000 Americans, and now we're around 625,000. The R0, the contagiousness of this is even more contagious than the great influenza. Although it's clearly not spread by birds, the spread of person to person is somewhere between 6 to 8, whereas the old Wuhan flu was 1.67. It's very well worked out. Why is this important? Because if herd immunity can exist, and we don't know that it can, but if herd immunity can exist, it's now estimated that you would need 92% of the population to have herd immunity. It's equatable with the R0, and we're not going to reach 92%. No one.
That's why those goals keep moving. When this thing first started, we were actually told 30 to 40%, then 50, 60, 70. Now you're saying with the Delta variant, because of how contagious it is, that we have to get into the 90s for herd immunity. Is the Delta more lethal than last year's COVID?
Yes, it's more lethal. Fortunately, for unclear reasons, it spares the kidneys, which reduces a lot of strain within the ICU. So you're not on a vent and dialysis and other things at the same time. That is an advantage to it. We're unclear about the long-term effects, but in talking to physicians in different parts of the world, especially in India, I was communicating with Saturday or Sunday night. They feel they're seeing more long COVID with this strain than with the other strains. And that would really put pressure on our healthcare system.
I want to ask a question about that in a minute. Dr. Cancio, you had mentioned immunocompromised. Would you just take a moment and tell us who is considered immunocompromised? It's interesting, in my rheumatology field, patients of ours in general with lupus rheumatoid of a moderate type, they are actually not necessarily more likely to get the virus, and they're not necessarily more likely to have a severe case. So one would think they should be, but that's not necessarily been the case. So would you give us a minute or two on immunocompromised, who that is, and what extra steps need to be taken?
Well, we obviously in our city, we have one of the busiest transplant programs in the country. So we have a large population of transplant patients. So in the definition of immunocompromised, transplant patients are a large population, and all of them are considered immunocompromised. Another group that is very much immunocompromised is the group of immunoglobulin deficient patients, like the common variable immunoglobulin. Those patients actually do not produce any antibodies to the vaccine. The vaccine doesn't work. That's a similar problem with transplant patients. They have a high percentage of not responding to the vaccine, and if they get the virus, they get sicker. So transplant patients, the immunoglobulin deficient patients or combined immunodeficiency patients, the patients that don't have a spleen seem to have an increased risk. The other population would be very advanced AIDS, not the HIV patient that is well controlled, but the one that has less than 200 T cells that is really considered AIDS, not just HIV, but AIDS. Also, the patients that may be on a significant amount of other medications like CellCept or high-dose prednisone, like for example, CellCept is being used for severe atopic dermatitis, for some of the other immunological diseases. So it has to do more with what the therapy is than with the disease. So if you have somebody that has atopic dermatitis and is using topical creams, probably no different. But if you have somebody with atopic dermatitis and is using CellCept and or steroids, that may be a problem, and so forth. So there is a large population of patients whose immune system is compromised because of transplantation, lack of immunoglobulin deficiency, immunoglobulin production because they're immunoglobulin deficient, advanced AIDS, no spleen, or the therapies that are being used to control their disease, such as high-dose steroids, Imuran, and CellCept, that puts them at increased risk.
What about diabetics?
Diabetes is not one that it is considered a higher risk if you get it, but you still produce antibodies. Your vaccine works. A diabetic patient will get vaccinated and is able to produce antibody, can be protected. That's not the case with transplants or immunoglobulin deficient patients or patients on CellCept. Those patients, basically, the vaccine does not protect them because they don't produce antibodies. The diabetic patient will produce antibodies. If they get sick, then it's a comorbidity that makes them have more complications. And so it's considered a risk factor, not as much a lack of response to vaccine.
So basically the two groups, those who are immunocompromised by their disease, some of them who are immunocompromised because of the medication. And then the second issue is some of them do not develop antibodies when they get vaccinated. So they would certainly be a group you'd want to push the booster on.
Well, not only that, but very important for those patients, and obviously I work a lot with transplant patients, is that we talk about the wall around them. Those patients don't produce antibodies, but the key to them is to behave like to protect themselves and to have the whole family and all of those around them form that wall of protection. So we spend a lot of time with transplant patients and with these patients that are unable to produce antibodies, in making sure that all the individuals around them form that wall of protection so that they don't bring it home, and that they know clearly that if they have any symptoms or a bad exposure, they must get those monoclonal antibodies immediately, because that's the way to prevent them from developing more disease. So that's a very specific group which we work. I mean, we educate them, we constantly work on that.
Thank you. Dr. Holt, Dr. Lockwood had sort of waded into this question of yours. And so basically, I just want to snapshot and update, how is Hillsborough County and our area doing? I think we've got 10,000 cases in the schools. We were ranked in the 92% worst or most vulnerable counties in the country, I saw. And then if you would, there has also been a word out there's a local oxygen shortage in Hillsborough County. If you could mention something about that.
Yes, sir. Well, let me go back to the vaccines, because, these birds are getting a lot of attention, and there's suspicion. People raise the question about the vaccine. The vaccine works very well. It will risk of infection by 10 times, and hospital 25 times. 90% of 98% of the cases that we sequence in Hillsborough County are Delta. So you get it, you got Delta. 99% of the cases, unvaccinated people in the last week. 99%. Deaths, 85% unvaccinated or partially. And those that are fully vaccinated, it's really not a vaccine failure, it's a host challenge as anything else. So I think it's very important that we dispel any question about the vaccine not working. And as far as the impact, I don't think the FDA impact will help, but employers are stepping up. The city government, the county governments, others are really, making people make a choice. If it's your free will not to be vaccinated, we're a right to work state. You don't have the right to a job. And I think, I'm proud of some of what the private sectors are doing. Yes, we have a lot of cases, but everyone does. I think we need these 92%. That's headlines. It doesn't matter. Not as much virus as almost anyone else. The Panhandle has worse, and again, on a per capita, but it's directly related, as Dr. Lockwood said, to your vaccine status. In the past several weeks, our 0 to 24, particularly our 5 to 18, are the only age group that show an increase. Everyone else was starting to go down. We appear to be flat for the last 3 weeks as far as new cases. Our percent positivity is drifting down since the middle of August. So those are somewhat encouraging. The hospital admissions and emergency visits are trending down, but the patients are sicker. And I would defer to Dr. Sinnott and Cancia. These are younger patients. They're very sick. They require a lot of oxygen, and across the country, and including ours. And what's I didn't understand is that you need liquid oxygen to really try to treat her. And why Tampa is so unique compared to others is we have surface water, and so it takes that's a much more with both temperature and other things that we get our water. It takes more liquid oxygen for our water supply compared to those that get it from underground. So we're not really worse off from our patients, but we're more dependent on liquid oxygen for our water supply. And I'll stop there.
Just I have one other follow-up, and that would be, let's say you are an employer, and let's say you have a shortage of employees. So you really, if you mandate everyone's got to be vaccinated, you may not have enough people to run your business. So what are some things an employer can do if he can't force the mandate? Masking, testing, what are some ideas you would have? And then also from a liability standpoint, as that employer, he's got an obligation to protect his other employees, doesn't he? So what are some things that employer could do if he's kind of in a fix and can't mandate everybody get vaccinated?
Yeah, there's no question. And unfortunately, as again, Dean Lockwood mentioned, that sometimes our minorities and our low income are the ones that are resistant to vaccines. The couple of things, testing is an alternative as far as both for protection, but also probably motivation for people to get vaccinated. The carrots, if you will, I don't know what's the threshold of how much money you can incentivize people to get. 250 seems to be sort of a starting point for many, and that's a lot of money to many people. It is very difficult. I don't have a simple answer.
Right. Some of the companies, I guess, are starting to charge an insurance premium for them. It's like charging a smoker more money. And some of them are making them pay for their own masks and some of them making them pay for their own tests, which can be pricey as well. So, you know, if you want less of something, then add friction to the process. And I think that's what a lot of employers do. Dr. Lockwood, so there is quite a bit of verbiage out there about masks being bad for children. So I was just wondering what you thought about whether wearing masks was bad for our school children.
Save the easy questions for me. So, you know, first, I think it is fair to point out that children are very, very low risk. And Doug will correct me, but I believe until now, only one person under 16 has died in Hillsborough County. So it is, they just are very, very low risk. So that really does need to be stated. And children under 12 are particularly low risk unless they have a unique immunocompromised state, in which case they ought not to be in school anyways. They ought to be homeschooled, or they ought to be in virtual school. You know, so clearly masking isn't really for the children. It's for the potential spread, and particularly if there are vulnerable folks in the house that are immunocompromised, whether it's parents or grandparents and so forth. And Margaret's already talked a little bit about creating that wall around them. You know, if you have an immunocompromised parent, that child perhaps might also be better off in virtual school, which fortunately the state provides. Right now, I think because the courts have ruled in favor of the parents, the counties will make their own decisions about that. I have a 10-year-old grandson who wears a mask, and I asked him this weekend, I said, Hunter, do you think about wearing your mask? Is it a problem for you at all? He looked at me like I was an idiot and said, no, not at all, Grandpa. I wear a mask. That's already become totally socialized in his brain. Now, obviously, he's an exceptionally intelligent child because he's my grandchild, but the bottom line is he's pretty ordinary and I love him dearly, but he doesn't seem to care at all. So, and clearly there are no medical reasons that kids can't be wearing a mask. You know, it's always an issue between the right of the public to have freedom and autonomy to make their own decisions, and our obligations as physicians and of the state to enforce public health. We don't allow people with active TB to go to school and cough. They're mandated to have treatment, if necessary, under supervision. If necessary, they're incarcerated. So there's a long history of English common law and American written law that allows for actions to be taken for the good of the public's health. But right now, I think for now, at least it's a moot point, since the courts have ruled in favor of the parents and thus in favor of the courts, in favor of the school districts. How was that for an evasive answer?
That's right. What did he say? So here's one. I understand USF has a Moderna vaccine trial going on for children. Do you have any updates on that?
They do, and probably Margaret or Doug or John would know more about it, but it is available, I believe, for children over 6 months. And there are relatively few contraindications that I know of to being enrolled in the trial. And I'll try to get that information, put it up on the chat.
Okay, very good. Okay, Dr. Sennett, so would you take a moment and briefly just grade the different vaccines that are available, Pfizer, Moderna, AstraZeneca, J&J, and maybe the Novavax that's coming up? Give us some grades on that, and why, and one of those things interesting to me is, why is it that Israel and the UK are seeing less vaccine resilience than, say, India was with this Delta? It's an interesting thing.
There are many approaches to vaccination. the more traditional approaches using polysaccharides, proteins, etc. And then there's some newer approaches. One uses an adenovirus vector to insert a specific gene. The second one is a more traditional polysaccharide vaccine, the J&J vaccine. I think the critical point to make is that you should take whatever vaccine is available. Long term, in the short term, we know that the mRNA vaccines are the best. Now, it's difficult to gauge what the best is, because when you examine the trials, what they did was they used different endpoints. And in using these endpoints, it's like a marketing issue. Like Pfizer and Moderna know that they don't want to come out and say Pfizer's effective 97% and Moderna's 96%. And although as doctors, we know that doesn't make any difference, but the uninitiated would say, oh, I'll get Pfizer. So the endpoints for Pfizer were death and admission to the ICU. The endpoints for Moderna were admission to the hospital and severity of illness. So you really can't directly compare them. I would tell you that the two premium agents currently in use are the mRNA vaccines. AstraZeneca's had some problems, but they're rare problems. They're, 6 people out of 600,000 develop a thrombotic event. What I tell people is get whatever they can, wherever they are, and look ahead to getting a booster. And this is an area I want to spend a second about. There's a lot of debate in the infectious disease community about effective boosting. One school of thought is that if you received Pfizer, the booster should be Pfizer. If you receive Moderna, the booster should be Moderna. Many people feel, however, if you receive Pfizer, the booster should be Moderna. And if you receive Moderna, the booster should be Pfizer. Those studies are underway right now, but from discussions with individuals that are looking not just at antibodies, but at T cell activities. Recall that we have CD4 and CD8 cells. The CD4 cells turn the immune system on, the CD8 turn them off. If you want to avoid the terrible ARDS lung problems, you're better off with having a preponderance of CD8 cells, of having more cells that turn the immune system off. And those actually seem to be more prevalent in some of the people receiving J&J and AstraZeneca. So it's an evolving story. To my understanding, to the world's understanding, everyone should be vaccinated as soon as possible. All of them will need boosters. I suspect we're going to find that you do better with getting boosted with a different vaccine because of its differing effects on the lymphocytes. But that's purely my opinion based on medical gossip.
And that's what they're doing in the UK, where Israel has kept them in the same lane. So it'll be interesting to see the difference. Dr. Cancio, could you take a moment? There's been a couple of references to long COVID or residual post-COVID. When I talk to my patients, I say it's kind of like your house caught on fire, you put the fire out, but you're still left with some damage. Well, tell us a little bit about long COVID or COVID residual.
There's, number one, it really doesn't correlate with how sick the patient was. If the patient's really sick, they may have a lot of pulmonary problems, but this non-specific, not feeling well, long-term consequences can affect anyone after COVID illness, even if it was not that ill. And it reminds you of chronic fatigue syndrome, where the person has involvement of multiple organs. They will talk about fatigue, lack of energy. They'll talk about muscle aches, joints, about brain fog. They just don't feel capable of doing the things that they were doing before. There are patients that, sure, they cough for 4 or 6 weeks after the illness, and but they get over it. But it's more a constellation of non-specific concerns. Even though you do every test in the book, they have normal set rates, they have normal CRPs, all their labs are normal, but they don't feel well. And you know that patient, you know that that was a patient that was very active, athletic, exercise, and now has all these new concerns and complaints, and there's not anything specific that you can do. One thing that in a small population has helped us is that there have been some reports that patients that have long haul syndrome that had not been vaccinated, once they get the vaccine, they feel a little better, which is an interesting thing. It could be that the antibodies have some kind of immunomodulator effect on those post-COVID type of symptoms, and it helps. But we'll have to see. And like Dr. Sena said before, one of our concerns currently is that we don't know what's going to happen with this Delta variant, and how many patients are going to develop this long haul syndrome, because we have seen a lot of mildly symptomatic cases in the community, and we don't know. And that's something that is going to be looked at, is whether patients that have Delta or COVID post-vaccine are different and have long-term effects different than the ones that had it independent of the vaccine. So this is a new disease. There are more questions than answers, but long haul does exist. Patients are very symptomatic. They don't feel well. They have this brain fog, weakness, fatigue, joint aches, and all the labs are normal, and they're very frustrated because there's no clear answer, and there's not much we can do except try to help them symptomatically.
Very good, thank you. Dr. Holt, a couple of things. Dr. Fauci says things are going to be better spring of 2022. What do you think?
Well, I hope they get I hope they get a little better quicker than that. But yeah, I think overall, that's a reasonable time to forecast. But how many times have my forecast been wrong? I think Dr. Lockwood has said Dr. Sinnott seems to be the best as far as our forecaster. So I think I would defer to him in that particular area of questioning.
Okay, let me ask Dr. Lockwood. So these major events that are supposed to spread, such as, hockey the Stanley Cup finals here, Sturgis, the motorcycle folks, or Lollapalooza. Are we seeing the spread from those that people kept thinking we were going to, or is it too hard to trace that?
Since we don't really do contact tracing, it is, but certainly we're not seeing the significant surges that we thought. And I think, part of it probably is that there is more latent immunity than folks think. So for example, we have about 183,000 documented cases. Doug would know exactly in Hillsborough County, but serological studies in Florida suggest that for every one documented case, about 3 undocumented cases. So if you begin to add up the number of likely total cases, and you multiply that times kind of the age-adjusted vaccine rate, which is going to be higher in that group anyways, lower in that group anyways, because it skews younger now. And you add those that are either partially or completely vaccinated, you're already around 70% just in Hillsborough. And yet we're still seeing this extraordinary 1,600 cases a day. So, clearly John's estimate of, a 90 to 95% number for herd immunity is probably likely. And then we'll probably have continued residual infections like the cold. I mean, literally a third of the common cold cases we have are due to coronaviruses. Well, where do you think they came from? They came from corona pandemics that happened, 2,000 years ago or 1,000 years ago. So, or more recently. So, I'm pretty confident that there's probably been spread, but I think that it's being spread in A, younger age group, B, many of them are immune, don't even know they're immune, and then a lot of them have been vaccinated. But, we'll see. The looking at the scenes from that vaccine, although God apparently intervened to make it rain to get the one in New York to dissipate. They haven't spread like we would have anticipated. Certainly they haven't spread like they would have 18 months ago.
I agree. I think in New York, actually, God didn't want to hear Barry Manilow. I think that's
right.
What he down.
Yes, and God and I share a very common aversion on that particular.
Well, you and God share many things, I'm sure. Dr. Sennett, let me ask you, I'm just going to run through a few things, Dr. Sennett, and we're starting to get closer to the end. We've got a bunch more questions on us. I have to go very quickly. So there's a bunch of things out there in the common world. Let me just run through them and you can just take a minute or two. So patients of mine who are scared to get a vaccine, but they're willing to take ivermectin. What is your take on ivermectin?
I think ivermectin is a life-saving agent for animals, livestock. Okay, it has no place in the treatment of COVID.
Okay.
In lower doses, you risk severe gastritis, GI disturbances, higher doses coma, higher doses in that death. People, it's my belief that people espousing COVID should be reported to the medical association and should be sanctioned.
Okay.
It is.
Thank you. How about hydroxychloroquine? Plaquenil?
Exactly
the same. So there are some nasal sprays that are being pushed by a couple local physicians that they say, since COVID goes in through the nasal passage for the most part, that these nasal sprays can block that. Is there any research looking at that?
I am quite aware of vaccines that are being investigated nasally. I can't imagine a topical agent that would act that way. I would have to know more about it. I don't understand how that, I know that certainly the nose is the route of entry through Kieselbach's plexus, and there's exuberant ACE receptors there, but I don't know how you would block them against something like that virus.
Okay, very good, very good. Let me just take a minute here. I've got a couple more questions. That's an ivermectin question. let's see here. Okay, so the next question, Dr. Sennett, was for you to say, when should you get a booster? This thing of 6 and 8 months, is that plucked out of thin air? Is that looking at I know the Israelis have showed Pfizer antibodies go down 6% per month or something of that nature. So where do these numbers come from, and what do you recommend just for the average person to get a booster?
Sure. First, Israel has done a wonderful job. You have to bear in mind that breakthrough does not refer to clinical disease. It refers to to PCR positivity.
Right.
Okay. So Israel does extensive testing. They find people, they are PCR positive, but they're not sick. So that is a little bit confusing. We have 5 studies that show that the vaccine is quite effective at preventing serious disease. It rates well above 80%. We have the Israeli study that shows 60-something%. But recall, a breakthrough doesn't refer to clinical disease. It refers to PCR positive. So we're looking at apples and oranges there. I prefer to look at whether they're sick or not whether they have a PCR.
Gotcha.
They're at least 88% and more on that.
Thank you. I want to just make a public announcement for those listening. We had referenced a trial at USF. It's for children 6 to 12 years of age. It's with Moderna. If interested, please contact Maria Elizabeth Enriquez Bruce, BRUCE, and she can be reached at Enriquez Bruce, ENRIQUEZ BRUCE at usf.edu. All right, let me see. Let me move on to Dr. Cancio. Dr. Cancio, they want to know, someone is asking or there's a whole, my understanding is there's a whole collection mechanism for post-vaccine reactions. Dr. Cancio, could you make a statement about that? Or that is being collected, that information, correct?
Yes, it's being, yes, there is being collected, and if you have given vaccines, whenever you give the vaccine, there is a paperwork for the patient in case that they want to report any findings, and that's being collected, and that's how very quickly any important side effects have been publicized, whether it's from one vaccine to the other. But still, there is, I cannot emphasize what Dr. Holt said before, vaccines are effective. Even when we're talking about the Israel study, I was just looking up the data. Even for Delta, in Israel, the coverage for Delta was 93% for hospitalization or death with the Pfizer vaccine. So it is effective. We have an illness that has a prevention. It's called vaccine and mask. It's unbelievable that we cannot improve and decrease the hospitalizations. But yes, there's a very good reporting and collection of side effects.
Very good. Dr. Lockwood, you get the final question here. So basically, you said I give you the tough questions. This is an easy one. You ready? This is from a listener. How can we morally explain ourselves getting booster vaccines when Africa has less than 1% vaccination?
Yeah. Well, it's not just a moral question, it's actually a public health question. Because if the rest of the world is not vaccinated, it really is a wonderful incubation setting for new mutations that will eventually reach our shore. So in a very practical way, we need to do everything we can to make sure the whole world has access to these vaccines. It's in our best interest. It's not a matter of being a do-gooder. It's very practical. And I believe that, it really the the developed world needs to do everything it can to make sure that the under-resourced world has access to these vaccines. It's in our best interest.
Very, very good. Thank you. Folks, this has been a very fast hour, and we've still got a number of more questions, but I wanted to thank everybody so much for taking your valuable time tonight to help talk to our audience, the physicians here in Hillsborough County. Thanks so much, everybody, and everybody, please stay very safe. Good night and God bless. Take care.